Good afternoon, everybody. I am thankful to organizers. Special thanks to Dr. Kunal and Office Bureaus of Infectious Disease Chapter. And thanks, Chairperson, my good friend Kanak Bhai. So when we are discussing this topic, that is diagnostic stewardship. Actually, this was a brainchild of me, Dr. Vijay Ule, and Dr. Basavaraj. And this year, we are running a beautiful module that is called as diagnostic stewardship across India. Almost we are doing the 45 programs across India with the academic grant from Bharat Biotech. I'm thankful to Mr. Mihir Bhai. He's here because he got the big grant, academic grant for this module and running a big way across India. So friends, coming to the topic proper, what is meant by this diagnostic stewardship? Yes, there is antimicrobial stewardship, there is X stewardship, etc. So the concept is n number of the investigations are coming, n number of investigation we are doing, and now what investigation we should go for. And for that, yes, right investigation, right antibiotics, right investigation, right patient, coming to a conclusion. So coming to experts, yes, I request first expert, Dr. Nikhil Bhai. He is a young dynamic idea expert. I request here to be on dais. Dr. Jayan Joshi, a mixed combination of the infectious disease and pulmonology. So definitely will handle the cases of the pulmonology. The third is Dr. Yashwant Rao, ES, infectious disease expert and his current treasurer of the infectious disease chapter. And fourth is Dr. Anand Keswan, a combination of neuro with the infectious. So let us, actually they should handle the various different cases what we are presenting for. So here, we are not discussing the treatment part, antibiotic, etc., etc. Whatever the cases actually we are presenting, these are the real cases. Our approach regarding the optimum diagnostic method to come to a conclusion, that part we are discussing in this presentation. So this was the basic concept, that is appropriate use of the laboratory testing, number one. Number two, for the guiding the patient management including treatment part. Third, optimizing the clinical outcome, and fourth, antimicrobial resistance. So coming to a concept of the diagnostic stewardship, that means the right test for the right patient and right time to coming to a diagnosis, and that will be definitely helpful for AMS, means the antimicrobial stewardship. Where is the timer? Excuse me? Just show me timer where. Is there a timer? Ah, yes. So coming to case 1 to Nikhil. This is a 15 months old female child, 10.2 kg weight, brought with a history of fever for 5 days, loose stool vomiting for 2 days, excessive sleepiness, non-projectile vomiting, non-bilious vomiting. Child was sleepy, in between fever also child was sleepy. This was a brief history. On examination, blood pressure 90/56. There was a little bit tachycardia with the tachypnea. Baby was febrile. Output was 1.1 ml per kg per hour. Hepatomegaly was present. Liver was palpable 4 centimeter. All central and peripheral pulses, good volume. And this was a case Nikhil. And this was admitted in the emergency room initially for the stabilization.
So,
Yes, wait. So, emergency room, this was the first report we did of this child. Now, our question is, yes, report is with you, how to interpret this report?
so if you see what my clinical diagnosis would be, it's a 10 months old kid who has presented with fever since 5 days, with tachycardia, with hepatosplenomegaly, with CNS involvement. So he's drowsy. The drowsiness may be because of the shock, or it may be because of the spread of the infection. So seeing this, I have kept it my clinical diagnosis as a febrile illness of short duration. And when you look at the video, you can see the child is having mild tachypnea, mild ascites. He has edema over the limbs, some petechial rash over the lower limb. So what has happened? So once you see the child, you feel that it's looks like a dengue. So when you see a CBC, the HB was 8, WBC 12,900, and more of a neutrophilic predominance. So there is a 63% neutrophils and a platelet on lower side. CRP is again 23. So when we have done the dengue profile, the NS1 was negative, IgG and IgM are also negative. So what suddenly it comes to my mind that clinically it is a dengue, but still it is, the reports have come abnormal. So I
So
would
friends,
again,
here, yes, Nikhil, same thinking process was ours. Yes, clinically we were suspecting dengue and the test was negative. We'll discuss that part later on. I want here, number one, yes, platelet is on lower side, hemoglobin is 8. Is there any significance of this with our
yes.
case?
So the other differentials which would I would still keep in mind would be malaria. The HB is on lower side, the platelet is on lower side. So even a falciparum malaria may present with fever, with hepatosplenomegaly, and with. So I would like to have a peripheral smear, a rapid malaria test. As far as the interpretation goes, HB on lower side means anemia, which may be present commonly with Indian kids. Neutrophilic predominance may suggest some infection and low platelet. So a
So
low platelet may be present with dengue, may be present with malaria, even with enteric fever. Enteric fever on may present with the low counts and low platelets.
So our thinking process was a little bit different as a, in the point of the whenever we are thinking in intensive care always such a things that yes my patient is edematous, rainy season, yes I am suspecting dengue, anemia with a low platelet definitely I can suspect that this could be a complication of dengue and now this is a worsening case of dengue may be possibility. A second thought process may be malaria but nowadays we are seeing less and less number of the cases of the malaria. But here looking part, one more thing that Nikhil, their CRP is 23. Is there any significance of this CRP in this case? Because there is a now fond of doing the CRP in each and every case after COVID. So,
So what we are now seeing is an epidemic of CRP positive cases. But we have to see that how to interpret a CRP. A CRP is just an inflammatory marker. It's a C-reactive protein. It is raised in multiple conditions. So it may be positive in infection, but we have to keep in mind that it may be positive even with viral infections. Some viral infections like adenovirus, COVID-19 may cause a raised CRP. One more thing we should keep in mind is the non-infectious causes of raised CRP. Like you may get it raised with any inflammatory condition. So anytime you are dealing with any inflammation, vasculitis, it may be a non-infective cause which is causing the raised in the CRP.
so you are absolutely right. That means the many times actually CRP we are doing in the day to the clinical practice. It is we can say that non-specific investigation. So it should not be used in isolation. If you want to use the CRP, yes, in NICU definitely with the CBC etc. and interpret in combination. But I can say that rather than positive, negative CRP has got more weightage. We can say that two negative CRP, yes, that rules out the infection. But positive CRP may not tempt us that we should start the antibiotics. Number two. Number three, it has got good negative predictive value. Previously, we used to say that bacterial infection CRP is high, but whatever the adeno last year we were seeing the cases, of course, CRP was high. COVID CRP was high. So it can be high in any case. Too high CRP may be going for the non-inflammatory or non-infective condition rather than the infective condition. This could be the fact of the CRP. Procalcitonin, no additional points of the added advantage of the procalcitonin, just increasing little bit 12 to 24 hours earlier as compared to the CRP. Let it be fashion investigation, we can say that a costly investigation, but not adding too much things. In the early onset sepsis of the NIS, we are not doing procalcitonin. Late onset, yes, we are doing the CRP as per the NNM guidelines. But please do not give the too much importance of the CRP. But in respiratory case, high CRP pneumonia, our high index of suspicion, it could be, last year we have seen a lot of cases of adeno.
Sanjay,
So,
can I just add one more point? So whatever we have discussed about CRP, one more important observation is if you have a rising CRP, then it
Absolutely.
will carry a very good significance. So if a child is running fever and if you are not able to come to a diagnosis in the first investigative lab, perhaps a rising CRP would be a focus towards bacterial infection.
Of course, that is an excellent point. And one more point, Jayanta, I have started the investigation in CRP early so and so much. That with the, how to assess the response to the antibiotics, that is dropping CRP, yes, very well you can say that your
Yeah.
patient is responding to the antibiotic.
Particularly important for osteomyelitis and septic arthritis.
yes.
So for deceleration and step down,
Yes.
you can monitor
Yeah,
CRP.
we can decide the course of the antibiotics too also. Nikhil, coming to your case again, this was a dengue negative, suspecting dengue still clinically dengue, but still everything is negative.
So
Can you interpret the test of the
one
dengue?
thing which I would say is no card test. So all these dengue tests should be done by the ELISA method. So we should not rely on this card test which come out negative.
Can I say that yes, strongly that even
No.
this is a dengue negative, everything is negative, it
No,
is
what
a,
we need to understand here is which test is positive on which day of the illness. So what we are looking as a day 5 of illness. NS1 is a very early marker. It usually starts to rise even on the first or second day. The problem is on fourth and fifth day, the titers go on decreasing. So what we are seeing is a fifth day child, fifth day illness where the titers may be low, and the IgM, it usually starts to rise from fourth and fifth day. So they become detectable on fourth and fifth day. So doing a test on fifth day, there may be a problem that we are in a gray zone where NS1 is still has decreased to levels and IgM has still not become positive.
that means you are saying that each and every patient I should go for IgM and antigen test like that?
No, sir. It is upon the day of illness when
Yes,
I am seeing.
absolutely,
So if I am seeing on first 2 or 3 days, I will do only an NS1. If I am doing on 5th or 6th day, I would stress doing more on IgM. And to
Absolutely.
look out for secondary, if a secondary thing, I will do an IgG.
Absolutely. So message here is remember that day 4, 5 of the dengue both can negative. And in that case, you can suspect that high index of suspicion, it could be a clinical dengue. Same thing happens with the patient further deteriorated with the ferritin was too high, retic was 0.4, lipid profile was high. Ultimately, it was a dengue with the secondary HLS treated with the methylprednisolone and ultimately improved and discharged. Coming to the case 2, to the pediatric pulmonologist as well as pediatric infectious specialist, Dr. Jayanta. Jayanta, this is 2 months old, trisomy 21, admitted with a history of cough, fever for 2 to 3 days. Baby was tachypnic, not accepting feeds, tonic posturing, 2 episodes. Neonatal history, mild birth history was there. Large PD was there. Yes, on admission, child was tachypnic, saturation at room air was 87%, there was a tachycardia, general hypotonia, and marked subcausal indraing was there. Initially, child was admitted in PICU, started on HFNC, eye fluids, anticonvulsants given. Baseline antibiotic started with cefotaxime amikacin. Initial profile of the CBC was HB 7.5 with the total count higher side 26,300. Platelet 44,000. CRP was too high 65. Urea was 65. Creat was 2.4. I think this is in AK also. With the hyponatremia, sodium 132 and potassium 3.1. Hypokalemia is there. ABG suggestive of the partially compensated respiratory acidosis with hypoxia. So child intubated, put on the mechanical ventilator. This was a X-ray suggestive of just yes. Jayanta, you can just comment in a brief one or two words about this X-ray.
So, if you look at this child, go through the history. Can I just go to the previous slide again? See, one more slide before. See, look at, there are several factors in this baby which can cause a respiratory compromise. A child who is born with a trisomy 21 naturally probably would be having a hypotonia, so naturally would be having a less cough reflex, more likely to get respiratory complications. The child has had a history of birth asphyxia. So again, we really don't know how much the child was oxygen dependent that time. He was in an ICU, there was a large PDA. Again, there was a history of NEC. So this child has had a very stormy course since birth. And particularly in this child, he has come with a high-grade fever and cough. So one must keep our alarms very high because this is a child who is likely to get complicated very fast. And as you can see in the investigations and the course of events, the child has worsened very rapidly in a very short span of time. And as correctly, the child has been intubated and put on ventilator because otherwise this child is impossible to maintain on oxygen alone. So what we can see in this child is that it is a rapid course of event in otherwise high-risk child, like Down syndrome or trisomy 21 child. So one has to keep a very high index of suspicion. There is also a possibility of aspiration here. So that I have to keep in mind also. But all said and done, probably the convulsion was only because of hypoxia or maybe because of other reason that we'll also rule out. But it's a conglomeration of all. It can be a sepsis presentation and it's a young baby. So we have to keep all these possibilities in mind.
Absolutely. That means whenever we are discussing infectious disease, important terminology is always, Jayanta, we are discussing whether how is my host, because that matters a lot. Whether it is an immunocompetent host or immunocompromised host. And most important thing that is picked up from the history by Dr. Jayanta is Yes, my host is immunocompromised host.
Yes.
So whatever the infection happens in the immunocompromised host, that will be different as compared to the immunocompromised host. And behavior of the infections in the immunocompromised host is always different whenever we are discussing for. And this is the X-ray just showing upper lobe pneumonitis with left lower lobe also. And this was a Jayanta child actually admitted in PICU. So there was a little bit respiratory distress, child intubated, still little bit coordinating with the ventilator. Now coming to the next part, subsequent progress of the case, LFT is also very deranged. DCD D-dimer was 1900, Procal was 0.6, ferritin was 454, LDH was high, cranial ESG, mild cerebral edema, echo was mild LV dysfunction, child was put on the inotropic support, requiring highest settings. Now here we have stabilized this child in terms of the intensive care, but always we are worried. Yes, I have started the antibiotics, that is the baseline antibiotics, what we have discussed for. And you are saying that this is immunocompromised, already we are labeled it as immunocompromised host, culture is negative. And here dilemma is, yes, what I should start, your CRP is high, whether I should going in the different way like that. So our thinking process like this, whether it is septicemia with the bacteremia septicemia with the bad pneumonia, or whether it is a gram-negative infections, because the gram-negative infections are quite common, whether it is a staph, because nowadays even community-acquired staph are quite common. So there is little bit confusion or there is more confusion like that. So how we will solve your confusion nowadays as per the certain recent guidelines?
So you are asking about the investigations.
Yes, I am
Yeah.
asking about the molecular test.
Because right now the child's condition is so critical that he requires an ICU setting. So all the treatment protocols have been done for the life-saving attempt. Now, we have been giving a broad spectrum antibacterial cover as expected. The supported treatment, the child has received transfusion also. A molecular test, well, if you want to come to a diagnosis of a particular microorganism, there can be several ones. The PCR respiratory, you have two panels, the upper respiratory and the lower respiratory. But if you are talking about this child, and if you are looking, if this child is continuing to remain sick beyond 48 to 72 hours, in spite of a good antibiotic cover, it will be the lower respiratory secretion PCR, which will be more relevant here. Upper respiratory PCR, or what you call the multiplex test, may not be that informative because you have variable organisms coming positive in that, and one cannot be specific in pointing out the diagnosis. Another thing is that rapid antigen test now can be done. As we all know, Dr. Bala Subramaniam from Chennai has been instrumental in propagating this. It is a very good test. It's a bedside test, comes quite really cheap, and it is for the detection of gas, that is a group A streptococcus, and it gives you a result. The specificity is very good, and it can give you a very quick result.
Bala is always saying whether it is a positive in the case of pneumonia, whether you can say that this could strep pneumonia in that case.
No, I think when you are talking about the upper respiratory infection, if you want to distinguish between a viral and a bacterial pathology, your RADT, suppose it comes negative, then it is likely to be more in favor of a viral infection. As you can see in this child, there can be several. It could be a bacterial cause also and a viral cause also. So one has to specify what exactly you are dealing with. And
Jayanta, here actually audience is very much confused about that, and our audience wants message that yes, this is a critical pneumonia, we know that. Taking sample is always a issue, especially non-intubated patients, and critical pneumonia, whether the upper respiratory panel will be helping in pneumonia diagnosis in that case.
No, upper respiratory panel should be generally reserved only for viral diagnosis. Something like an influenza, or maybe we went through the pandemic that time, the COVID diagnosis can be informative for upper respiratory, because it also matters how you collect the sample. Because the sample collection is not correct, your report is not information. If you are dealing with a pneumonia diagnosis, probably the lower respiratory would be more informative, because you have a lot of other organisms which can be detected through that.
Yes, absolutely. That means whatever we are discussing, that the upper respiratory panels, absolutely told by Jayanta, that is restricted with a certain disease, yes, COVID, influenza, what we are saying that about the, yes, if it is a critical pneumonia, definitely upper respiratory panel is useless, because there is growth of the mixed growth, maybe viral bacteria, etc. Very confusing to denote for the diagnosis, just losing the cost. In that case, Jayanta, whether you can, yes, in case of immunocompromised host, they are saying that in case of immunocompromised host, if there is a panel is growing that only one organism, so in that case, we can just give levitate. Otherwise, using the upper respiratory panel in the pneumonia case will be useless, except the two conditions, yes, flu, influenza and COVID. Rather than that, whether we can go for the lower respiratory panel in that case.
Yes, and particularly it should be on the BAL sample because that will be more informative. Collecting a upper respiratory, the difference between collecting a sputum sample and upper respiratory sample is going to be always a technique which is involved. So it is very important that you do a lower respiratory panel for detecting the bacteria, and through that you can have diagnosis which is confirmed for several organisms, particularly mycoplasma. You can have strep pneumoniae which can be detected through that. You can have pertussis which can be detected through that. So it's very informative in that regard, and it picks up multiple pathogens. It can also get us some information about resistance also.
Absolutely. That means, friends, the message that is given by Dr. Jayanta is this is a case of severe pneumonia. In spite of the immunocompromised host, better to go for the lower respiratory panel rather than the upper respiratory panel in that case. And only patient is intubated very easy to take the minibal, etc. Only patient is intubated. Non-intubated patient, yes, with the already Mahesh has mentioned about the bronchoscopy. Yes, fiber optic bronchoscopies are there. We can take the sample very well. In the bigger babies,
As mentioned by Dr. Mahesh in his talk in the morning, I think BAL is one particular thing which we are underutilizing. So if we can make use of that, because it is not that difficult to perform. Bronchoscopy will require more elaborate arrangement, but BAL can be easily done and it can be more reliable sample which can give you information about the cause.
absolutely. So ultimately, in this case, BAL done, and the report came as adenovirus positive. Final diagnosis was adenovirus pneumonia with the CCF with AKI ALF, and subsequent with the due course of management, patient improve and discharge. So learning points, friends, here are CBC, CRP just corroborative, blood cultures in the pneumonia, many hardly 18-20% growth. Upper respiratory panels in the restricted cases, H1N1 yes, COVID yes, rest of the things no. Yes, BAL, minibal in the intubated patient, definitely going for respiratory panel will be helpful for specific diagnosis, and that gives the excellent results too. Coming to the third case, Dr. Anand, this is 9 months old child case. There was a fever for 2 days, no clinical focus, and whenever we are suspecting the UTI, actually these are the certain guidelines. We can straightway go for the questions. Yes, this was a report of the urine, Anand, and see the reports. I am showing the certain parts in the report. Bacteria pleasant, pus cells 12 to 14, nitrate negative. My question here is, Anand, is it the case of the UTI to start the antibiotics?
Yeah, good afternoon. So diagnosis of UTI in children below 2 years very, very important. So here we can see that pus cells are 12 to 14 and the bacteria present. But not mentioned how it is collected. It is centrifuged, uncentrifuged. It is from which collection you are not mentioned. Anyway, you can say the pyuria means if it is more than 5 WBC per high field, it got 72% sensitivity and 48 to 82% specificity.
That merely there are the WBC you may not means that this could be UTI. Huh? That is number one.
Yeah.
That just merely pyuria cannot be UTI. So always we are going for the cultures. Anand, here this is a culture report of this patient.
So again, here important point is that how you collected the urine. Whether it is from the bag or it is
Absolutely, absolutely. You are very smart. Huh? So this is 10 raised to 5 colony count. You want how the sample is collected.
So we want to know how to collect it.
So tell the little bit guidelines that yes, the collection of samples
So
and
very, very good collection if it's suprapubic puncture, it's a 100% specificity, and also midstem also, almost 100% specificity. So catheter sample, it is only 95%, but you can see that clean catch will get a colony count of more than 10:5 is significant, and a symptomatic patient, even 10 to 2 also very significant. And here, 10 to ratio of the 5 is not very, very cut-off figure, but you have to correlate clinically also, according to age also.
so here message that is clear cut about the UTI given by Dr. Anand, merely WBCs in the urine is not a UTI, it could be merely a sterile pyuria also. If you want to diagnose UTI, better to go for culture. If you want to go for culture, the culture collection method is important. Accordingly, the colony count how much you must know for. If it is suprapubic puncture, definitely any pathogen colony count we are considered as a positive UTI. So these are the clear-cut messages from Anand case. With another case of Dr. Yashwant, this 11-year-old female brought to this of fever for 8 days, body ache weakness for 4 days, swelling over face and eyelids 2 days, altered level of consciousness, and breathlessness for few hours. Child drowsy, there was tachycardia, tachycardia, yes, hepatomegaly, pallor was there, bilateral capitations, reflexes brisk, plantar not elicitable. So this is a case, yes, Yashwant.
Good afternoon. This is a case of fever for more than 8 days with breathlessness and all the history which Sanjay has mentioned. It looks to me like acute encephalitis syndromes. It can be a viral encephalitis, malaria, or ADEM, or any rickettsia, or mycoplasma infections.
So actually same line actually we are managing this case as a AES because drowsy patients, acute, and then all these symptoms showing like a rickets, showing like a AES. But the thing actually what actually we have missed here was patient was not exposed.
Yeah.
And on day 4, patient was exposed by one of my nursing staff, and this was a story. So typical rash is there in this patient. Can you explain the Ishwant what is a rash?
So fever, most of the time fever without foci for more than. It is said clinically, undress and look for the patient in areas where you look for rash. Probably it looks like a maculopapular rash, specifically around the elbow area, cubital area. So probably it looks like more of a rickettsial infection.
Here is a rickets expert is in the audience already. He is just seeing the case. Dr. Atul, he has seen the lot of case of rickettsia ultimately. With this such a rash and everything, nobody will miss that this could be a rickettsia, of course. So this was a rash. So subsequent progress of patient, there was dropping in the platelet count, worsening of the patient, and ultimately after picking the rash, this was the story. ELISA was positive. My question, Dr. Yashwant, is that yes, it is a case of rickets everybody knows now. Many times treated with a doxy and ultimately patient improved and discharged. My question is here about many times actually many of the pediatricians are doing this test that is called a Wilflix test. Now we are not discussing Vidal because we have updated the Vidal test like that. But now actually Atul, Ashwin Sud, everybody has highlighted rickettsia so much that everybody does the rickettsia and everybody starts the doxy like that. So in that case, how much significance of the Wilflix you will give for in your diagnosis of rickettsia?
See, basically in the first week, Wilflix is not so important. PCR is very important.
Whether it is a specific test or just a screening test or whether you will not give that much importance for this test?
It is basically an antigen test where antigen of rickettsia and as protease is used. We have different antigens OX19, OX2 and OXK, where clearly shows that in scrub typhus OXK is positive, and it shows antigens, and the sensitivity is very poor. It is basically a screening test.
So friends, here message is this is a non-specific test. False positivity is there. Sensitivity is too low. So it should not be taken as a confirmatory test for rickettsia. And whenever we are going for the diagnosis of rickettsia, so these are the confirmatory tests. Of course, when the diagnosis of rickettsia in the second week, antibody test. In the first week, PCR-based test. This should be the correct way of diagnosis of the rickettsia for confirmation of the diagnosis. And of course, excellent results are with the doxy. Now I am taking the next 4 cases in rapid fire 2 minutes. Be alert of all our experts. First case again to Nikhil. Nikhil, this is a 2-year-old child brought with history of the fever. In all investigation negative, ultimately frustrated and blood culture was sent. And this was the culture report. It shows that staph albus. Now my question is whether start Cloxa, wait for sensitivity report, or might be MRSA, start linezolid, ignore, repeat the sample.
So anytime we send a blood culture, we should have something in the mind that which organisms we are suspecting. So when you get a culture report in your hand and you get an organism like Staphylococcus albus, you should think that is it correlating with clinically with my case. Now Staphylococcus albus is a normal skin contaminant. It is usually found in the skin flora. And it is most probably, for this case, it is most probably a contaminant. It is usually a skin colonizer. And it is not very specific organism where it should be treated. So for me, in this case, it would be, I would ignore the blood culture, wait for the, look out for the other causes of the fever. And if still the fever is persisting, again with a good sample, if required, I can take a repeat sample later on to look out for other.
Absolutely all right. That means this is a contaminant, that this comes in the cons group of the category. But friends, remember here one more cautious that is about the cons. If it is an immunocompromised host, yes, that should be taken as a serious infection. If it is an immunocompromised, yes, you can take it as a cons, as a contaminant like that. So important message regarding the blood culture, already everybody knows that take a set of the culture, 1:5 ratio should be there, cleaning up everything should be there. And this is a way of the sample collection, set 1, set 2 like that, one is aerobic, another is anaerobic, and the quantity depends upon the age. Next case is for Jayanta, I think this is for Jayanta also. 22 months old child presented with history of the vomiting 2 days, fever 2 days, distension of abdomen. Jayanta was since last 1 day. Child was abdomen was grossly distended, pain in abdomen, reduced food intake. Child was pallor, dehydration was there. There was a tachycardia, pulse was low volume. Then RS was clear, abdomen, distension, guarding, tenderness, everything was there. Patient was conscious. This is the first set of the investigations with the HB 9.4, total count 6,900, platelet normal. CRP again, Jayanta 138. Actually, they are very much fond of doing CRP here. Already we have discussed that CRP part. Electrolytes, hyponatremia is there. ABs is little bit metabolic acidosis. Urine, ketone plus stool, occult blood is there. So this is the X-ray. And question to Dr. Jayanta is, already child started the meropenem because whatever you are maybe suspecting. And these are the 3 questions, whether to send for blood culture, what could be the probable clinical diagnosis, whether I should take the pediatric surgical opinion or whether go for exploratory laparotomy. What are the key questions?
Yeah, so now if you look at this case, it appears to be that there was an infective pathology which has got complicated and the child has got worsened over a period of time, a short period of time. So all the parameters which are suggestive of a child going into a possible septicemia, and there could be an additional peritonitis. So blood culture, only one set.
That means you are suspecting this could be abdominal infection. Hope so.
Yes. Yes. So probably we are dealing with an intra-abdominal infection. Perhaps for the age of the child, it has gone to a sepsis with multisystemic involvement. All the systems seem to be getting affected. You have investigated for the...
So you want to send the blood culture. Suppose I am your student and I want to ask that, sir, I want to send the blood culture. What the specific things actually in such a case?
See, as Nikhil mentioned, I think if I am suspecting an intra-abdominal infection, I am looking at a pathology which could be multiple bacteria getting involved. So what is more important is we must send the aerobic as well as anaerobic culture.
Absolutely. Here. So in the message here is in intra-abdominal infection, always these are the mixed organisms, gram positive, gram negative, and anaerobes. So what Jayanta rightly told that a set of bottle, that number 1 is aerobic and second is anaerobic. Next.
Second thing is that in spite of the antibiotic cover and the support treatment, the child seems to be worsening. So it is very appropriate that you investigate. Probably you will definitely take a pediatric surgical opinion, and the choice of investigation, now we have a bedside USG which is available everywhere.
Jayanta, USG is normal. USG is normal.
I think we should do a imaging CT scan for this child, or MRI, which probably will give us any septic focus which has been hidden, which has been missed out for this.
My patient is not affording.
But in that case, probably you'll have to take the surgeon's opinion, and stabilizing the child, you'll have to go for exploratory laparotomy.
That means the number 1 already message given by Jayanta, 2 set of the bottles, aerobics, anaerobics, because always mixed flora is there, gram positive, negative, and anaerobes. Second message, if non-affording, pediatric surgical opinion, let surgeons will decide whether to open or not. So in affording patient, yes, we can go for the abdominal CT, because even though ultrasound normal will not rule out everything is normal in abdomen, because abdomen is such a magic box. Yes, something can be missing in this case. So
no, let me just add here, if I am quite confident about my pediatric surgeon and his clinical acumen and the expertise, I would leave it to the surgeon to take a call. I mean, like if he wants to open, because looking at the child's condition, it is such a critical child that any time wasted would be detrimental. So if a surgeon feels that if the child is stabilized and go ahead for surgery, that would be also a good alternative, because again, you are wasting some time in doing a CT and getting the report.
age of the child is 24 months. What could be you are suspecting 24 months?
Most probably it will be gram negative.
Yes. And infection is there, but what is this?
Like,
Whether
if
it is,
suppose, I don't know exactly the diagnosis, but if suppose there is a rupture of the viscus anywhere, there could be some maybe there could be a hidden abscess somewhere. So you are probably dealing with multiple organisms.
You are absolutely right, Jayanta. We'll take the surgical opinion and we'll let surgeons will decide all the things. About the culture, we already discussed. Will not again repeat same things again. Let's see the course of the case, Jayanta. Child was deteriorated, mechanical ventilated, blood culture sent, and gram negative bacilli 12 hours just was first. CT abdomen was surprising in the 24-month child, reveals a retrocecal appendicular collection. That was a little bit rare things. Operated emergency appendix was done, and drainage was done, and ultimately child improved. Here my question is, Jayanta, many times actually in such a case still we are confusing about the antibiotics, and there is pus in front of us. How, whether we should send the pus and how to send the pus in this case?
See, during surgery, you must collect the sample from the operative site, the secretions, and you must again send it in two, the aerobic as well as anaerobic.
Whether there are any separate pus culture bottles to collect the pus?
No. You can take it in the routine bactec bottles also. They are good enough. Only thing is they should not be refrigerated. They should be transported as early as possible.
Absolutely. That means blood culture can be taken into, pus can be collected into blood culture bottles. Proportion may be the same. One important point Jayanta highlighted that whenever you are taking the pus or blood culture should not be refrigerated. But on other hand, urine culture, yes, that should be refrigerated. This is another message I want to give for.
Only if there is some delay.
Huh?
Only if there is a likely delay. If it
Yeah,
can be
yes.
transported immediately, nothing.
Yes,
like it.
yes. So this was a case open. Ultimately, it was appendicitis with lot of adhesions, abscess, etc., and improved and discharged. Now, there was growth of the organism in this patient about the pus. And see the organisms are E. coli and they are sensitive to ertapenem. Any decision you can take in this patient?
See, now as we have understood from various antibiotic stewardship modules, now because the child's condition was critical, he was given the maximum antibiotic cover. Clinda was given, I think vancomycin was added, because that time we were not zeroing in on the organism. Meropenem was also added. So perhaps after the culture report has come, and it shows a sensitivity, your operative intervention has been done, the child has been stabilized, so there is no need to give all three antibiotics. You perhaps can zero into one, maybe go to
very well you can de-escalate and go for as per the protocol. So this is the certain key messages. CT may be helpful in certain cases of missing, abdominal ultrasound may miss certain things. So this is the last case for this Yashwant. Yashwant, this is 9-year child admitted with the refractory status epilepticus, has received a ceftriaxone, transposed further care, intubated, central line, catheter, neurosurgeon, neurologist advised the steroids, methylprednisolone given, and ultimately initially stabilized. Now there is a new onset of fever in PISU. And of course, whenever in PISU, always we think in these two terms, CLAPSI and COUT. Can you highlight a little bit part of this CLAPSI and COUT, what is meant by, and how to do tests in that case?
How do?
First, what is my CLAPSI and what is my COUT?
See, possibly because the setup was in the ICU, we suspected it as a catheter-related one or catheter-associated UTI.
So basically, first part is the central line associated bloodstream infection. Second part may be the catheter-related urinary tract infection. Of course, everybody knows that. I will going into her in the short fashion because already the time is up. Just I am finishing that part. Whenever we are discussing of course, the CLAPSI, the two samples should be taken, one from periphery, one from central, and which sample growth the first, accordingly your interpretation should be whether these are true organisms or false organisms. In COUT, definitely the catheter should be removed, that is first part, and how sample should be collected in case of COUT? From the same catheter line?
No.
Yes, in that case catheter must be removed and you put the another catheter after cleaning, and in that case the second sample should be collected for the urine culture. So these are the certain guidelines. In this patient there was a growth of the organism, this was gram negative, and when you are suspecting Yashwant, always gram negative are the 4 bugs, of course E. coli, Klebsiella, Pseudomonas and Acinetobacter. Can you give the certain guidelines about the audience regarding these 4 organisms?
So basically we know that the 5 organisms you have said, we have to know whether it is enzymatic one or due to a non-enzymatic one, because we have on mind carbamase producing organisms. So basically they will be lactase producing and non-lactase producing organisms, among which lactase is E. coli and Klebsiella and Enterobacteriaceae, and lactase fermenters are Pseudomonas and Actinobacters as well as Burkholderia.
Absolutely. That means suppose there is a growth of the organisms in the culture plate, and if they are growing in the both at aerobic and anaerobics, and if they are lactose fermenters, most likely these are the E. coli and Klebsiella. But if they are going into the one that aerobics, not anaerobics, and they are non-lactose fermenters, most likely this could be the Pseudomonas and Acinetobacter. Why it is important? Because nowadays genetic testing is possible because culture takes 4 or 5 days to have a sensitivity. So in that case, always we go for the expert carba. And in the same patient, we did the expert carba. And what is the report? Yes, the report was OXA48 was detected. Whenever we are saying that this gram-negative bug having OXA48, definitely these organisms have inherited resistance for the all carbapenems. And the carbapenem will not work, they will not work in this case. And of course, drug of choice will be ceftazidime avibactam, ultimately started on this patient and improve and discharge. So these are the advanced methods of the diagnostics. Yes, Malditop we'll discuss in the subsequent part, and for that, definitely you attend the diagnostic stewardship module. That is 4.5 hours module. We have discussed right from basic to advanced diagnostic method with the case-based module, almost a lot of discussion over 4.5 hours. So whatever the advanced tests, Malditop, film array, everything will be discussed in that module. I think with this, we have covered a lot of cases. Only the CNS part is remaining, but definitely in the next part, next subsequent, the chance whenever we'll get, we'll discuss about the CNS, rapid diagnostic methods and various panels in the CNS. I am thankful to organize again and audience, even post lunch, the hall is full. I am very much thankful for audience for patiently, and of course, all my experts for doing a great job. Thank you very much.